Having looked at the overall structure of the autonomic nervous system, it's time to dive into the nitty-gritty. And that has mostly to do with neurotransmitters and receptors. And I'm going to warn you right now that this annotated PowerPoint is not going to be enough. You definitely need to watch my my whiteboard video on ANS receptors. You really have to know your adrenergic and cholinergic receptors. They're going to be sort of introduced in here, but I go into them in more detail in my whiteboard video. So neurons that release acetylcholine are called cholinergic neurons. Look at cholinergic comes from acetylcholine. This is so easy. There's no reason ever to get this mixed up. Acetylcholine is cholinergic. And then neurons that release norepinephrine are called adrenergic. And I explained this in the whiteboard video in more detail. But epinephrine is also known as adrenaline, and norepinephrine is very, very similar to epinephrine. You can think of it as being the same, and you won't lose anything at this level, all right? So adrenergic neurons are neurons that release adrenaline, or noradrenaline, or norepinephrine, which are all basically the same thing. So just get that in your head right now. Sometimes I see students mix these up, and there's no reason to do this. It's so easy. Acetylcholine, cholinergic. Adrenergic is for adrenaline, which is essentially the same as norepinephrine. Adrenaline, alternate name for epinephrine, similar to norepinephrine. In both branches of ANS, really divisions, I should say, preganglionic neurons release acetylcholine. So at the ganglion, it's acetylcholine in both cases, sympathetic and parasympathetic. And as a result, we don't really care. That's really not an important factor then, because it's the same for both. It's going to be at the organ where things are different, and that's where we're going to care. So in postganglionic, neurons in sympathetic release norepinephrine. Some postganglionic release acetylcholine. There are a couple of weird exceptions, and that has to do with the merocrine sudoriferous glands, all right? So remember that's the sweat that cools your body. That's going to be a weird exception, but that's really the only one that we're going to care about, all right? And it is going to be important, though, later on, we'll see. But generally think of the sympathetic nervous system as the adrenergic nervous system. Sympathetic is adrenergic, with one big exception, the merocrine sweat glands, okay? And most postganglionic neurons in the parasympathetic release acetylcholine. So at all of your organs, you know, the parasympathetic controlling, you know, the thoracic and abdominal organs, it's releasing acetylcholine on those organs, all right? Now, agonists of acetylcholine. Acetylcholine, one of the principal neurotransmitters in the human body. We've seen it all the way since the neuromuscular junction. That was the first neurotransmitter we ever looked at. Nicotine is an agonist. So nicotine grows in a lot of plants in family Solanaceae, the deadly nightshade family. So tobacco, eggplant, tomato, henbane, mandrake, belladonna. All right, so nicotine is found in the tissues of a lot of those plants, and it is an agonist of acetylcholine. So at some acetylcholine receptors, nicotine will activate those receptors. Not only will acetylcholine activate the receptor, but nicotine can activate the receptors as well. And that's why we call some acetylcholine receptors nicotinic, because they're activated by either acetylcholine or nicotine. Then muscarine is another agonist found in nature, found in a lot of mushrooms in genera Clitocybe and Inocybe. These are not the psychedelic mushrooms. These are generally mushrooms that make you sick. But muscarine is found in a lot of other plants as well. But there are some acetylcholine receptors that will not only respond to acetylcholine, they will also respond to muscarine. So we're going to call those muscarinic receptors. Now, do muscarinic receptors respond to nicotine? No, they don't. Do nicotinic receptors respond to muscarine? No. All of them respond to acetylcholine. It's just that some respond to nicotine in addition to acetylcholine. Others respond to muscarine in addition to acetylcholine. So let's look then at the acetylcholine receptors. Two kinds, nicotinic and muscarinic, which I just mentioned. Nicotinic bind nicotine as an agonist, as well as acetylcholine. Nicotinic receptors are fast-acting ionotropic receptors with immediate but transient effects. And so the postganglionic receptors in the ANS are nicotinic receptors. Postganglionic means the receptors that are actually on the ganglia, all right? These are receptors at the ganglia. So remember remember the sympathetic nervous system and the parasympathetic, it takes two neurons to get to the organ. So at the ganglion, we're not really doing anything except, it's like relay runners. You just got to pass the baton. So what we want here are really fast-acting receptors that just pass the baton. So it makes sense that all of the receptors in both sympathetic and parasympathetic at the ganglia are nicotinic receptors. And that's why we're not really going to pay much attention to them anymore, because it's the same for both divisions of the ANS. There's no difference between the two. We're just trying to get the signal from preganglionic axon to postganglionic. And nicotinic receptors are just a fast way to send it through. Now then, muscarinic ACH receptors bind muscarine as an agonist in addition to acetylcholine. These are slower acting metabotropic receptors with delayed but longer lasting effects. That's why we have them at the organs. The organs are what are actually doing the work, so we want the effect to last longer there. So all the visceral receptors in parasympathetic division are muscarinic receptors, all right? So that means that when the parasympathetic nervous system is talking to your heart, to your lungs, to your stomach, to your intestines, and so on, it's using muscarinic receptors in every case, okay? Every single case. Now, as we mentioned before, there's that one weird exception in the sympathetic. Sympathetic is always adrenergic receptors at the organ, except for the merocrine sudoriferous glands, which use acetylcholine, release acetylcholine onto muscarinic receptors. That's the weirdo exception. Now, adrenergic receptors. So these are receptors that respond to norepinephrine. These are the receptors of the sympathetic nervous system, with that one weird exception at the merocrine sudoriferous glands. These are the sympathetic receptors. So most visceral receptors in the sympathetic division are adrenergic. Adrenergic are classified as either alpha or beta, the first two letters of the Greek alphabet. They could have called them A and B, they could have called them, anything, but they just, they wanted to be fancy. They used the Greek alphabet. So, in other words, there are adrenergic receptors that are alpha receptors, and there are some that are beta receptors. What do all of them respond to? Norepinephrine. Norepinephrine will activate all of these receptors. So why are there different ones? Well, they're found at different places in your body, and they have different effects. It allows your body better control over specific kinds of responses to various stimuli and situations that are out there. These are all metabotropic, so they're longer lasting, slower to take effect, longer lasting. So, alpha-1, these cause peripheral vasoconstriction. That increases your blood pressure. Makes sense when the sympathetic nervous system kicks in, you're in survival mode. Higher blood pressure means more blood faster to your organs, to your heart, to your skeletal muscles. You got to survive right now. Now, make sure you watch that whiteboard video, because I talk in there about how the alpha-1s also do pupil dilation, which is also very important for survival. Alpha-2s I don't mention in this PowerPoint because I don't test you on them, but I do mention them in the whiteboard video, and you should learn them. You really should, because some instructors do cover Alpha-2 in Bio 201. You will have to know them when you get to Bio 202. You absolutely will. So you might as well learn them now. It's just I won't test you on Alpha-2s. Beta-1 receptors go to the heart, where they increase contractility and heart rate. So your heart will beat faster. Contractility, also your heart will beat stronger as well. All right. Now in the whiteboard video, I also mentioned how they go to the kidney, where they stimulate the release of renin, which is a hormone that raises blood pressure. So notice in all cases you're raising blood pressure. Beta-2 receptors go to the lungs, where they cause bronchodilation. They also go to the liver, where they cause your liver to turn glycogen, the stored form of glucose, back into actual glucose, which it dumps into your bloodstream. Now think about those two together. Beta 2 receptors are increasing the amount of oxygen in your body, and they're increasing the amount of glucose. Why do you do that? Because if you're fighting for your life, you're going to be having to make a lot of ATP, and to make ATP you need oxygen and glucose, so it makes sense. So beta 2s are the oxygen and glucose receptors, okay? They also vasodilate blood vessels to the skeletal muscles and to the heart. So notice here that alpha 1s vasoconstrict, beta 2s vasodilate. You're thinking, wait, why would you both vasoconstrict and vasodilate? This comes back again to the fact that these receptors are found in different places. So alpha 1s are in peripheral blood vessels out near the surface of your body. Notice that makes sense in several ways from a survival standpoint. By constricting them, you're going to raise the blood pressure. It also means that if you get scratched or bitten by the chupacabra, you'll bleed less because those blood vessels are constricted, see? Whereas internally, blood vessels going to your heart and your liver and your skeletal muscles, we want to increase blood flow to those places. We want skeletal muscles to fight and to run. Heart, you know, we need more blood. We need more glucose, all right? So it makes sense why we vasodilate to the liver as well. So alpha 1, beta 2, those are the ones I'm going to test you on, but make sure to check out that whiteboard video. You should learn also your alpha 2s and beta 3s. It's not that much harder, and you will have to know them in Bio 202. I promise you will. And notice then what would happen here. What if we were to block beta 1 receptors? What would that do? Well, that would decrease your heart rate, decrease the contractility, and that would decrease your blood pressure. So guess who takes drugs that are selective beta 1 blockers? Yeah, people with high blood pressure, all right? So those of you heading for nursing school, your first semester you're going to do pharmacology, and believe me, you will cover alpha or all the adrenergic receptors like crazy, because drugs are based on these. So many high blood pressure is such a common problem, especially in Western civilization, that there are tons of drugs that try to work on high blood pressure, and the drugs can work in different ways. So look at an alpha 1 blocker would also lower blood pressure. So would a beta 2 blocker. Why do you use one versus the other? Maybe people are on other medications and you got to watch for side effects. See? So this is why knowing your adrenergic receptors is such a big deal. Lots of drugs affect them, and you have to know all the different ones, because some kinds of people can take alpha 1 blockers, some people can't, some people can take beta 1 blockers, other people can't. This is an important thing to know. So as another example, albuterol, sold as Ventolin and Proventil, is found in the rescue inhalers used by asthmatics. Which type of adrenergic receptor do you suppose it affects, and or would it be an agonist or an antagonist of that receptor? So think about that for a minute. Albuterol, which kind of receptor? Yeah, beta 2, because those are in the lungs. And what is it going to be? It's going to be an agonist, because it wants to, you want to open up. When somebody's having an asthma attack, you want to open up their lungs. So notice these are selective agonists. What would happen if it were a non-selective? And originally they were. Originally in the development of drugs, they didn't yet have drugs, or they didn't really know which drugs affected just beta 1, just beta 2, or both beta 1 and beta 2. What would be the danger of taking a beta 2 agonist for your asthma attack if it also stimulated beta 1 receptors? It might also increase your blood pressure, see? And what about if you took a beta 1 blocker, or let's say you took a beta blocker for your high blood pressure? What if instead of just blocking beta 1s, it blocked both beta 1 and beta 2? Not only would it lower your blood pressure, it would make it harder to breathe. So see, that's why it's important to have selective beta blockers, okay? Do you see now? This is going to be a big deal when you get to your pharmacology. So here you go, just a slide that summarizes nicotinic, and I circled there beta 1, beta 2, alpha 1, because those are the ones I make you know for this class that I test you on. But you should also look over those beta 3 and alpha 2. You will have to know them in the future, I promise. So, which of the following statements is false? Muscarinic receptors are a type of adrenergic receptor. Cholinergic preganglionic axons are relatively long. Nicotinic receptors are ionotropic. Postganglionic axons in the thoracolumbar division are relatively long. Sympathetic effects are the same as adrenergic effects. Holy moly, look at all the things you have to know to answer that question. These are the kinds of questions that I will have as multiple choice on your next exam. So make sure you can do these, all right? You need to put all this info together. It's not just about memorizing facts, it's about understanding concepts and interlinking it, weaving it all together so you can understand them. And what's wrong here? Yeah, muscarinic, those are cholinergic receptors. Those are for acetylcholine. All the others are true, so you should take a moment right now and go back through and make sure you see why they're true. So now we got to talk about that weird exception, all right? The integumentary system. It's a bit of an oddball when it comes to the ANS. All of the accessory structures are activated only by the sympathetic. So there's no parasympathetic fibers going to the accessory structures of the skin. Remember, what were the accessory structures? Sebaceous glands, sudoriferous glands, erector pili muscles, all right? So only sympathetic goes to those. And in particular, American sweat glands, the ones that cool your body, they have sympathetic neurons, all right? But they release acetylcholine onto muscarinic receptors. It's not my fault. There's nothing I can do about it. They didn't consult me when they designed the human body. It would be great if it were all just easy, just nothing but norepinephrine working on adrenergic receptors, but it ain't. And there's nothing I can do. So you just have to remember, this is the one weird exception. And remember then, you can remember that this is sympathetic. Even though it's acetylcholine being released onto muscarinic receptors, you can remember that American sweat glands are sympathetic because you need to, that's for perspiration, for sweat. You need to cool down. When you're fighting the chupacabra, you're going to produce heat from all the ATP, so you need to cool down. The sympathetic nervous system cools you down. So apocrine sweat glands and piloerector muscles have alpha-1 adrenergic receptors. So notice that's sympathetic as well, but in this case they behave the way they should. So sympathetic nervous system, yeah, it's going to make you sweat in your armpits. It's also going to make all your hair stand up, but thank goodness those are norepinephrine released onto alpha-1 receptors. That's why, once again, the only weirdo are the American sweat glands. Sympathetic nerves, but they release acetylcholine onto muscarinic receptors. Now, anticholinergic effects. This is also a big deal. Many common prescription and over-the-counter drugs, OTC, over-the-counter, including tricyclic antidepressants, SSRIs, remember the serotonin selective reuptake inhibitors. What were those prescribed for? Depression. Those are the most common antidepressants in the world. Antipsychotics for the poor schizophrenics and the people that are having trouble distinguishing what's real from what's not. As well as antihistamines, all right, for your cold and allergies. They have anticholinergic side effects. So a lot of these drugs, all right, they don't necessarily directly affect cholinergic receptors, but overdoses of these drugs can affect them, and they will block the acetylcholine receptors, specifically the muscarinic receptors. So why is this a big deal? Well, think back. So dual innervation, right? Organs are getting both sympathetic and parasympathetic signals. Now, one way to get sympathetic effects is to directly activate sympathetic receptors. But what happens if you block parasympathetic receptors? If you block muscarinic cholinergic receptors? Well, that's going to accentuate sympathetic effects. In other words, the parasympathetic won't be able to activate. Therefore, you'll only have sympathetic activation. So therefore, anticholinergic effects are very similar to sympathetic effects. All right? So I'll say more about that in a moment. Now you might wonder, well, why would people overdose on these? Yeah, you know why. SSRIs, antidepressants, you know. You get dumped by your boyfriend or girlfriend, you feel bad, you go home and you already got a prescription for Prozac or Zoloft or whatever, and you decide since you're feeling especially bad, you'll take twice as much. Will that help? No, but what it will do is give you anticholinergic side effects. It'll raise your blood pressure, it'll decrease salivation, all the other sympathetic type effects. Antipsychotics, these poor people, oh my gosh, you know, they're supposed to take their medication twice a day. They can't even remember which planet they're on. They may take their meds 5 times a day, all right? It's not their fault. They're not doing it on purpose, but they end up with anticholinergic side effects. Antihistamines, yeah, you know, you get a cold, you go to the store, you buy that bottle of, you know, day flu, night flu, whatever, what do they call those things? I can't remember. You know, the bottles, Theraflu, all that crap. And you know, if you read the label, it says you're supposed to take like 2 teaspoons every 4 hours. Is that what you do? Admit it, you don't. You take the damn bottle and you take a big swig of it, and like 20 minutes later you're not feeling better, so you take another big swig of it. Is that going to make your symptoms any better? No. But it's just going to give you anticholinergic side effects. This is a common emergency room phenomenon. You know, urgent care. People show up. They don't know what the hell's going on. They feel weird as hell. They're sweating. They got high blood pressure. You know, they got dry mouth. You know, what's going on? Yeah, these are anticholinergic effects. All right. So, these drugs block acetylcholine receptors, predominantly the muscarinic. Remember, muscarinic found at postganglionic parasympathetic. So these drugs disrupt homeostatic balance. By inhibiting parasympathetic, you end up with effects that mimic sympathetic. All right. Common symptoms include confusion, agitated behavior, dilated pupils, blurred vision, flushed skin, rapid breathing, tachycardia, which is fast heart rate, hyperthermia, all right, you're overheating, dry skin, dry mouth, and urinary retention. So look at those just briefly. You should be able to figure those out. One thing here I didn't really mention before, acetylcholine, a neurotransmitter in the brain that has to do with attention and memory and stuff. So what happens is if you block the muscarinic acetylcholine, then people get confused, okay? Agitated behavior, because you're getting those. Well, what happens when people get confused, all right? What happens if somebody's trying to explain something to you and you don't understand it? Yeah, you end up getting pissed off. So confusion naturally is agitated behavior. Dilated pupils, all right, because parasympathetic constricts. If you block parasympathetic, you can't constrict. Blurred vision, remember parasympathetic controlled accommodation of the lens, so now you can't focus very well on up-close objects. Look at flushed skin and hyperthermia. Remember, the weird exception, the sympathetic, the Merocrine sweat glands, they were acetylcholine onto muscarinic receptors. So if you block muscarinic receptors, you can't sweat. What happens when you can't sweat? You heat up, hyperthermia. Also, your body will try to compensate by vasodilating your peripheral blood vessels. It'll try to bring blood up to the surface so that the air can cool it down. So you're going to look red, all right? Rapid breathing, because again, sympathetic activation of the lungs, all right? Dry skin, you can't sweat. Yeah, you can't sweat. You're blocking the Merocrine receptors. Dry mouth, you can't salivate. Urination, parasympathetic, you can't pee. So look, it all fits together. And there's an old saying that they use, they teach the doctors and the nurses how to spot anticholinergic effects. Mad as a hatter, blind as a bat, red as a beet, dry as a bone, hot as a hare. So mad as a hatter, you're like the Mad Hatter at Alice in Wonderland. You know, you're talking nonsense, you're confused, you're agitated. You can't focus on close-up objects, your skin is red, you can't salivate, you can't sweat, you can't pee. Hot as a hare. So hares, a type of logomorph, like rabbits, they run normally a higher body temperature than humans do. So what's going to happen, your anticholinergic effects, you can't sweat, so you're going to overheat, and you're going to have a body temperature closer to what the body temperature of a hare would be, like that black-tailed jackrabbit you see there, which we have right here in our desert. So I put this slide in. I'm not going to go over it. You can read this yourself, but it tries to explain the whole cluster of anticholinergic effects, all right? And remember, on an exam, if I ask you for anticholinergic effects, don't give me the little memory devices, mad as a hatter, blind as a bat, hot as a hare. I won't give you any credit for those. Those are just to help you to remember the actual effects, which I do want you to know. Confusion, agitation, delirium, anterograde amnesia, pupils dilated, can't focus on near objects, etc., 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 okay? So this slide, read it over on your own. See if that helps. Just kind of a little clinical example here, the belladonna alkaloids, family Solanaceae. I've talked about this before. The deadly nightshade family includes lots of things, including peppers and potatoes and tomatoes, but also lots of these weird plants that people have known about for centuries. Belladonna, deadly nightshade, henbane, mandrake, jimson weed, the sacred datura. Belladonna alkaloids include atropine, scopolamine, hyoscyamine. These are all medical drugs, but they also produce anticholinergic effects, and sometimes they're used intentionally to produce that. All right. Extracts of these plants have been used as medicines and poisons throughout history. Belladonna, by the way, Italian for pretty lady. Women, especially women, how shall we say it? Women of the late afternoon, shall we say, who need to make money by looking attractive. So yeah, some belladonna drops dilate pupils. A lot of studies have shown that dilated pupils, you look more attractive than constricted pupils. Still used medically to induce amnesia, decrease bronchial secretions prior to surgery, alleviate motion sickness. We talked about that. Scopolamine, transdermal scopolamine reduces motion sickness. So yeah, and cool book. Carlos Castaneda, anthropologist, Journey to Ixtlan. He worked with a Yaqui man of knowledge, a medicine man, Don Juan Matus, taught that the sacred datura is an ally that teaches the female spirit, whereas peyote teaches the male. These anticholinergic drugs can produce a sort of a hallucinogenic. It's really not hallucinogenic per se. It's a dissociative state in which you're not really connected to reality. Sometimes people take them as recreational drugs. Brugmansia, another member of the family found in South America, used by criminals to induce stupor and rob victims of their cooperation. All right, so watch out. Little ANS terminology. So sympathetic nervous system, we talk about these as adrenergic effects. Sympathetic effects, adrenergic effects. All right. We can also call them sympathomimetic effects because they mimic the sympathetic nervous system. Because parasympathetic uses acetylcholine, we often say cholinergic effects. All right. So in other words, increased heart rate, increased bronchodilation, all that kind of stuff. We call those adrenergic effects. Whereas pupil constriction, decreased heart rate, bronchoconstriction, we call those cholinergic effects. All right. Just get used to that. Those are standard terms. Also, parasympathomimetic effects. That's a lot of syllables for one word, isn't it? And although it's true that preganglionic neurons in both sympathetic and parasympathetic release acetylcholine, the word cholinergic is really reserved for the parasympathetic. You never talk about the weird sympathetic exceptions. You talk about parasympathetic effects as being cholinergic effects, or really vice versa. When you hear somebody talking about cholinergic effects, they mean parasympathetic nervous system. And you can see there, the illustrations are just from like nursing textbooks. So adrenergic, fight or flight. Anticholinergics, can't see, pee, spit, or shit. Hot as a hair, dry as a bone, red as a beet, mad as a hatter, blind as a bat, right? Cholinergic, salivation, lacrimation, urination, diarrhea, GI distress, emesis, sludge. That's a little different than the one I gave you. That's cute. Adrenergic blockers, feed, breed, pee, and poo. So it's all cute. Nurses, they love to have cute things. True or false? An overdose of muscarine, found in some species of mushrooms, will produce anticholinergic effects. True or false? Overdose of muscarine, anticholinergic effects? No, overdose of muscarine would produce cholinergic effects. Muscarine activates muscarinic acetylcholine receptors, which means that you will have cholinergic effects. People sometimes who pick wild mushrooms and don't know quite what they're doing, and they pick some of the poisonous ones, guess what's going to happen to those people? They go home and fry them up with some butter and some garlic, eat a whole bunch of these mushrooms, and they have massive muscarinic acetylcholine receptor activation. What are these people doing? Oh my God, they're oozing everything from everywhere. They are salivating, lacrimating, urinating, defecating. They got stuff coming out of every opening on their body, okay? That's what would happen if you did an overdose of muscarine. You would have cholinergic, not anticholinergic.